first of all, let me say thank you very much for being here on a Sunday morning. I really appreciate that. Um, Let me just, I know you're by training a nephrologist, internal medicine, you're doing research in that area. Can you give us a little bit of your background for those that aren't familiar with you, if you don't mind?
Sure, absolutely. Well, yeah, really happy to be here. It's quite a privilege. I'm a little bit of, I still feel like a little bit of an outside from the low carb and, carnivore community, because this is pretty new to me. But professionally, as way of a brief background, I'm a clinically trained nephrologist and a physician scientist, which means I also run a basic science laboratory and also see patients only, in the inpatient setting. My research interests have been focused a lot on kidney injury as well as sepsis metabolism. Sepsis, being this inflammatory state that occurs as a result of a very severe infection, of which we see this a lot in the hospital, and a lot of patients end up with acute kidney injury. And so my lab has been very much interested in trying to understand the pathophysiology of that. And a lot of that, interestingly, during my postdoc, we were studying the purpose of, anorexia that's induced by infection. And we were studying different models of bacterial or viral inflammation and trying to understand what would happen if we fed animals when they stopped eating. And it was interesting because in bacterial infections, it seemed like feeding animals worsened their outcomes. So there was a lot more mortality. But the effect seemed to be a little bit different, almost opposite with viral infection, where if we fed the animals, they did a little bit better, actually. So we have been interested in trying to understand how these metabolic changes are actually potentially wired to promote different defense mechanisms when you get acutely ill. And I've been more interested in trying to pick through the fasting metabolic pathways that get induced in the context of bacterial infection. And that's actually brought me back into kind of, understanding ketogenesis, metabolism, and right now I'm moving my lab towards trying to understand kidney metabolism, because that's kind of a field that has been difficult to study because the kidney is a little bit more complex than the liver in terms of the different types of cells that compose the kidney. And so there's a little bit of an aspect of the ketogenesis and fasting metabolism in my professional world, but personally, I and my husband have gotten into the low carb world because my husband's a type 1 diabetic. And so for many, many years, he had been struggling with dealing with, large swings in his glucose. And even though all his endocrinologists were very happy with, his A1C being 7 or lower, he was not physically feeling very well because, following the 88 diet, you basically have a roller coaster of glucose, and was often getting sick, having a lot of migraines. And so I would say probably about 5 to 7 years ago, he ran across Dr. Bernstein, learned about the low carb diet, and that was the first step for him to start feeling better and having a lot more control over his blood glucose. But it still wasn't, there was still kind of a deficit. It wasn't totally perfect in terms of how he was feeling. And so more recently, we've been working with Paleo with the PKD, Paleolithic ketogenic diet, to help deal with kind of the other autoimmune aspects of his type 1 diabetes. So he has a lot of the other sequelae in terms of the Hashimoto's hypothyroidism. He's got vitiligo. He also has IgA deficiency and a lot of other things that these autoimmune consequences of type 1 diabetes. And we're now a lot more interested in trying to address the autoimmune aspect of it rather than just the glycemic control. So that kind of in a nutshell is both my professional and my personal kind of entry into the low carb carnivore world. And for me personally, so I'm a thin, as you can see, Asian American, Chinese American background. And interestingly, both my parents are type 2 diabetics. And so I'm also on a low carb diet. I spent about a month on carnivore and it didn't work too well for me, but nevertheless, I'm still mostly animal based, and I would say low carb, like less than 50 grams of carbohydrates a day, and trying to fit more into the paleo medicina diet based, like basically only eating root vegetables at this point. Because I can see that with the way my parents have gone, eating still more Chinese ethnic based, but a little bit more westernized, larger carbs, and probably if I only gained about 15 pounds of weight with excess carbohydrates, I probably would be diabetic in about a few years had I not switched my dietary patterns a few years ago. So this is, my background and kind of how my family has changed. And I've been able to convince my parents a little bit. They're not 100% low carb, but they've at least started to change their ways and are improving their glycemic control. But that being said, I think there have been a lot of questions, and I think this is what you want to talk about today is, as a nephrologist, and in an academic setting, I'm constantly being faced with kind of the more mainstream ideas that, protein is going to kill your kidneys and eating too much fat is just bad for you altogether. And it's been very hard because the high protein diet being bad for your kidneys that idea has perpetuated for so many years. And the hypothesis it's almost been ingrained into physicians' minds. And it's very hard to change despite the fact that the data is very poor. And I think the other aspect is especially in the nephrology world, is that it is true that by the time your kidneys are at the point of failing and the patient is going to require dialysis, there is a point at which too much protein becomes a bad thing physically, because the kidneys can't handle the amino acid and therefore the acid load. And then protein becomes something that has to be restricted dietarily. But with respect to normal kidney physiology, I think it's hard to say that a high protein diet per se, in and of itself, causes damage to the kidneys.
There's a whole bunch of stuff in there. Thanks for that introduction. I just so many questions I want to delve into. One thing, when you refer to, your husband, and a lot of this is, it's not till it strikes at home that you kind of look around and say, what are the other options? Because I know it's interesting when you look at surveys as an orthopedic guy, they would do surveys on orthopedic surgeon. Would you have a knee replacement? And most of the orthopedic surgeons would say no, and they were doing them. It's kind of like, wait a minute here, what's the inconsistency here? But the fact that the ADA accepts a hemoglobin A1C of 7 or just under 7 that's fine. Right. I think that's a shame. And I agree with Bernstein in the fact there's no reason you should not have normal blood glucose, as a type 1 or even a type 2. Particularly when you're using insulin, because you can do that, particularly if you're willing to adjust your diet. There's no reason whatsoever you should have, a 6.5 or 6.7 or 7.4 or whatever. I think the average hemoglobin A1C for type 1 diabetics, something like 8.3. That's average. And a lot of people are like, well, that's about where you're going to be. And, you'll accept the 250s, the 270s, and the swings up and down, and as it's, chasing carbohydrates is a really daunting task, and you either overcorrect, undercorrect, because you're using these kind of huge boluses typically for most people. And even the pumps and the artificial closed loop pancreases are not doing much better. I mean, you're still sitting there with a hemoglobin A1C of 7.3, 7.4. So that is a shame. And hopefully more people will realize that you've got to, rather than just, kind of like you're chasing your tail when you're eating carbohydrates with that. The other thing is that I want to dig into, because you said, as you get towards dialysis, we're looking at, stage 4, renal insufficiency, or, however you class. I'm sure you're more better with the classification than I would be, but there's a point where people have mild insufficiency. I've personally seen that improve when people eliminate processed carbohydrates. They improve just their diet in general, and even if they're eating a high protein diet. So we do see some recovery of renal function. That's been my experience. I don't know if there's enough information you can share. I mean, I wonder, and this is another thing that I often see, because, I'm a big guy. I'm 6'5". I'm 250 pounds. I got a lot of muscle. I work out hard. I eat a lot of protein, and my GFR is not high based on creatinine, and my serum creatinine is often high. But if I go and get a cystatin C test, and I'm not sure how much you utilize that, it says GFR is 118 based on that. So, I mean, as you know, they're both estimated numbers. And we see a lot of people that go on a high protein diet and their serum creatinine bumps up 1.25, 1.3, GFR is lower. Can you talk about the physiology behind that? Because I think a lot of physicians are not aware of this. And I think it's something that just needs to get out in the public, because there is even among physicians who should know better, even among probably nephrologists who should know better, they don't seem to recognize this phenomenon.
Yeah, absolutely. So like you just said, both of those markers are used to estimate your glomerular filtration rate, or GFR. And so that the GFR is a measurement of kidney function. But unfortunately, in order to get a very accurate measurement of GFR, you would have to use a substance that is both inert, it's freely filtered through the kidney, and then the kidney doesn't do anything with it. It doesn't reabsorb it, it doesn't secrete it, and it doesn't metabolize it. So therefore, that substance, when it's either ingested or injected, whatever comes out of the kidney is how much your kidney is filtering, right? That would be the perfect measure. And we do have measures like that, but it's quite onerous and very difficult to do if we're going to do it on every patient who gets a kidney function test every time they go to the lab. Okay, so it's not something that we would do routinely. So the way creatinine or cystatin C has been used to generate equations to estimate your GFR is that they do a study, they recruit study subjects, right? And then they measure the serum creatinine or the serum cystatin C, but they also undergo the gold standard, right? So they get injected with one of these substances. Some of these are called like iohexol or iothalamate or something heavy labeled that we can distinguish from whatever you make in your body. And then that typically involves some blood tests as well as a urine collection. And then they accurately measure the GFR using one of those markers, and then take the creatinine number, and then they take a whole host of other variables, right? So now it becomes a statistically generated equation. And typically what ends up going into the equations are things like age, gender or sex, and ethnicity or racial background. They did include in these studies a lot of other clinical parameters that may contribute to the estimation of your GFR, and they come up with an equation. So that way, when a patient goes into the laboratory, they get a blood drawn and they get the creatinine measured. They plug it into that equation with a couple of other variables, and it spits out an estimate of what your glomerular filtration rate is. And with the initial studies using creatinine as the estimate, they found that age, sex, and race tended to be the most highly, independent variable that was strongest in creating the best estimate of what your GFR is. But there's a lot of limitations, right? So, a lot of these studies were not very large. I mean, and for nephrology and for some of these types of studies where you have to do these more involved GFR measurements, I mean, 1,000 patients sounds like a lot, but if you think about it, once you do the equation, you're averaging that entire cohort. And then now when you're looking at each individual patient, you have to ask, does this individual patient actually match the cohort of patients where they generated this equation from, right? And so the creatinine has a lot of limitations. It's limited by muscle mass because creatinine is a byproduct of muscle turnover of creatine. It's also what you eat. So if you're a vegetarian, so you don't eat a lot of meat-based protein, which would be another creatinine load, or you're you're carnivore, or you're a highly animal-based, meat-based person. And then muscle mass is a huge thing. And so the reason age is often and sex is entered into the equation is because men and women have different muscle mass. And then as you age, you typically lose muscle mass. But then the issue, and then more recently, actually, the race variable has come into question too, because people are feeling that there are both scientific and social reasons for why people are upset with the race equation. But the fact of the matter is that when they generated this equation, race, Black versus non-Black, turned out to be a very good variable to correct for the actual creatinine measurement and to estimate what the GFR is just based on a creatinine. And that, again, I think reflects the fact that people of African descent tend to have more muscle mass than non-African people of African descent. So, but that being said, people who are, African American, not all people have the same muscle mass. And so we're all generating these estimates based on an average of the data that came out of this cohort. Cystatin C is another marker that's been studied quite a lot, but there are also limitations to cystatin C. So cystatin C is something that is produced by probably all cells in the body. It's assumed that it's at steady state, meaning that it doesn't really go up and down a lot. But the problem is that there are some suggestions that some things like inflammation can change the expression or the production of cystatin C. There's also issues with the laboratory. So different measurements, they've shown that there's kind of a drift over time such that sometimes the laboratory result, the measurement itself, is not as accurate. But cystatin C does not have the dependence on muscle mass. And so at least for that part of the estimate, changes and differences in muscle mass doesn't affect the cystatin C estimate as much. But all of that to say is that whenever you get these measurements, it's still going to be just an estimate. And you have to look at the number and also your individual person or the patient in front of you to make a clinical judgment of what that really means, right? So I think there is another alternative that isn't as invasive. So you could do like a 24-hour urine collection and measure creatinine clearance. And even then, there's also a little bit of a wiggle room of that may be an overestimate in part because creatinine is something that is freely filtered through the kidney. It's not reabsorbed, but it is secreted. So about 10 to 20% of the creatinine that ends up in your urine is actually secreted into the tubules. So that can also interfere with the true estimate. But that being said, it'll be a better estimate than just a one-time blood draw with a spot measurement. But people don't like to do that, partly because, doing a 24-hour urine collection is also cumbersome. It's often fraught with either being under collected or over collected. And so if some people don't kind of adhere to the instructions and have the full 24-hour collection, you might be, if it's under collected, it'll be underestimated. If it's over collected, you're overestimating it. So those are kind of some workarounds, but I think one of the things to remember is that the way these things are generated, they're all estimates. And so if you want to have a true measurement, you'd want to have one of these gold standard tests done. And I think one of the bigger issues, probably a more systemic problem is that we often just use whatever number that the lab spits out, right? And rather than including other clinical parameters and using good, medical clinical judgment when you're working with a patient, right? And taking all of these variables into account, understanding the limitations of the creatinine and or cystatin C, and going from there and seeing the patient's progress, and also maybe creatinine numbers over time, rather than just using, a one-time value and then the equation to assume that that is the accurate GFR of that patient.
Yeah, I want to just delve into, because you talk about renal metabolism, and when I was in medical school, and I really enjoyed physiology, but I didn't much care for renal physiology. It was painful. It was, calculating all the ion flows, and it was just a very, it's I think most people would admit it's very difficult. I think the same thing with cardiac electrophysiology. I thought those were both very difficult subjects to really, compared to some of the other physiology. But I guess there might be some hepatologists that might say they think the liver is pretty complicated too. But regardless, let's talk a little bit about renal physiology and renal metabolism. I guess that's the word I want to get into, because you talked about metabolism. We don't really hear about kidney metabolism. We hear about the physiology,
right.
But the metabolism. What's going on with kidney metabolism, and tell us about how does ketosis and fats and proteins and carbohydrates affect this, good or bad, and maybe some of the things that take-home points that we would want to know.
Okay, yeah, that's a great question. And actually that's an area that I'm trying to move my research program into, in part because, and yes, liver metabolism is complicated. The reason why kidney metabolism creates another dimension of complexity is because the kidneys are made up of nephrons, so that a nephron is a single unit of the kidney. And so each nephron has a filtering unit, and then the filtering unit joins into this tube-like structure. And that tube-like structure is composed of many, many, many different types of cells. And each cell has a different function in terms of whether it is going to reabsorb or secrete all sorts of different electrolytes. So sodium, potassium, calcium, magnesium, as well as water balance. And the kidney, not only there are several different types of cells, they're all arranged in a very specific order so that you are maximally able to control all of these electrolytes and the amount of water that the body ends up holding onto versus excreting out into the urine. And so as a result, all of these different kidney cells actually have different metabolic substrate preferences. And a lot of these studies were done years ago where they actually micro dissected little parts of the tubule, and then they would dump different things like amino acids or different fatty acids or glucose and things like that to see how much energy they could generate with the different types of substrates. And with those experiments, they discovered that, in fact, throughout the entire tubule, all these different cell types have different preferences, right? They'll utilize different substrates, and the outputs may be different as well. But one thing we do know is that there are parts of the kidney, so the proximal tubule, meaning the first part of the tubule, that part has aspects that are similar to the liver. In fact, it is capable of doing gluconeogenesis. And my lab, we're quite interested in understanding whether or not that part of the kidney can also do ketogenesis. Because we found that the rate-limiting enzyme to make ketones is increased in that part of the kidney in fasting conditions, and also during sepsis, during a bacterial inflammatory state. And but it's a little bit more difficult to really prove that it's making ketones, because in other parts of the kidney, there are cells that burn ketones for energy, and they preferentially use ketones for energy. So it's possible that ketones are being made, but then in one part of the kidney and then used in another part of the kidney, and then you're not really able to see net production. Whereas in the liver doesn't express the enzyme to burn ketones, but it makes very high levels of the enzyme that makes ketones. That's why it's a really good producer of circulating ketones, because it doesn't burn what it makes. So in that respect, we're making small progresses, and we're generating more tools. We haven't really had the tools to study kidney cell specific metabolism, because once you kind of take samples from a whole tissue, and you can't really make inferences from what these single different types of cell populations are doing when you mix them all together. So kind of to make a long story short, we don't really know a lot about kidney metabolism. And I'm hoping, as part of my research program, to really delve into that question and understand how is kidney metabolism regulated. And I think moving forward, a lot of questions will arise. How does kidney metabolism get altered in the context of disease like diabetes? How do different nutritional inputs affect kidney metabolism and ultimately kidney function? And I think there's certainly a lot to be learned. And right now, one of the biggest barriers that we're trying to push through is kind of the technical aspects of studying each of these different cell types, and being able to get very more accurate and precise information based on each cell population one at a time, which is quite a challenge, but I think will be critically important as we understand kind of what happens in a lot of the diseases. Diabetes is by far right now still the #1 cause for end-stage kidney disease. And so understanding how what optimal kidney metabolism is and how it gets diseased are two really important things that we still need to work out in the research world.
I looked at this about 3 years ago, and I was really reading, trying to figure some of these stuff out and see some of these relationships. And when we look at diabetes, there's obviously a relationship between diabetes and insulin. There's many, particularly type 2 diabetics, are hyperinsulinemic, maybe later they become, insulinopenic, I suppose, or like a type 1 diabetic. But how does the relationship between insulin and the kidney, I know it'll lead to a retention of sodium and fluid typically. And then is there a relationship between insulin and the kidney and vitamin D? I know the kidney is also very essential for vitamin D conversion. Is there a relationship between hyperinsulinemia and vitamin D, or has that been worked out, or can you postulate that there might be something like that going on?
So I'll comment a little bit about what you've said in the beginning. So insulin, there's been a lot of talk about hyperinsulinemia and the effect on blood pressure and sodium retention. That's been ongoing debate in the research world, partly from conflicting data from animal models. But I would say, based on the vast majority of data, I would argue that there is definitely some relationship with insulin, especially hyperinsulinemia, that drives sodium retention. Whether that's a direct effect or an indirect effect, meaning that whether it's insulin signaling on kidney cells and making them hold on to and reabsorb sodium, or an indirect effect of hyperinsulinemia causing some other signal to the kidney to hold on to sodium is still not completely worked out. And yes, the kidney is quite involved in vitamin D metabolism, and it is important because it expresses 1-alpha hydroxylase, so it activates vitamin D. However, I'm not aware of a direct relationship between hyperinsulinemia and the activation of vitamin D within the kidney. That I'm not 100% sure. I've not read about it. There could be, but as far as I know, I'm not sure that insulin is directly involved in modulating renal vitamin D activation.
Yeah, I think as I recall, and I may be incorrect, this is because about 3 years since I looked at it, but I thought it was maybe a secondary effect through maybe calcium. And I think, I just looked at a paper the other day. It showed that hyperinsulinemia induces a relative calcium diuresis, same with magnesium in the kidney. Have you seen anything about that?
So, insulin deficiency?
No, I think it's insulin overexpression. So hyperinsulinemia drives the renal losses of magnesium and calcium. At least that was a paper I think I looked at from, gosh, I think might even been from the 1940s, believe it or not. So it's been a while. So obviously the techniques have improved back then, and maybe the science has changed a little bit.
Yeah, I'll have to take a look at that. So I would say it gets to be a little bit more complicated to study because with the effects of hyperinsulinemia or insulin deficiency, and I think part of what I was mentioning, the question of whether or not it's a direct or an indirect effect, that makes it a little bit difficult to tease out. So, for example, if you look at the different states of type 1 diabetes versus type 2 diabetes. So I would say, for example, in type 1 diabetes, when people are initially presenting, they're in an insulin deficient state. And as a result, they have hyperglycemia, and the hyperglycemia gets to a point that you're peeing out a lot of glucose, and the glucose becomes an osmotic driver. And that drives a lot of water as well as other solutes. And other solutes can include, sodium, calcium, magnesium, potassium. All of those are being dragged out with the glucose in the urine. And that tends to basically drive this volume depleted state. And so a lot of type 1 diabetics, when they're presenting, they're actually volume depleted, their blood pressures are low. And this is in the context of not having enough insulin, peeing a lot of glucose, and driving a lot of the solute out. Whereas with type 2 diabetes, it's a little bit different. So they're both hyperglycemic and hyperinsulinemic. And in a lot of those cases, there seems to be some sort of reflex, whether, again, it's insulin direct on the kidney or some indirect effect driving the kidney to actually hold on to sodium, even though it's also typically a lot of patients are still peeing out a lot of glucose. They're not presenting like the typical type 1s when they're first being diagnosed, right? They're hypertensive, while the type 1s are usually either normal blood pressure or low because, they're getting so volume depleted. But then if you look at patients who have insulinomas, okay, they have a tumor that's expressing and making a ton of insulin. Their blood glucoses are typically either normal or on the low end. And they're not reported to have any blood pressure problems. So it's hard to say, like you would argue or other electrolyte problems, if insulin is the sole driver of, I would say magnesium, calcium, sodium, really high levels of insulin in these patients of insulinomas, you would expect that they would have these physiologic abnormalities as well, but they don't. So I think that in the context of diabetes, either type 1 or type 2, there are other factors that are mediating kind of the presentation of either high blood pressure or low pressure that has to be taken into account. And it's not insulin in and of itself that's driving the phenotype.
Well, that's a great answer. Let me ask you about, so many of us, there's obviously people in this audience eat a lot of meat. They're eating, many of them, a lot of protein. What are your thoughts on salt with blood pressure, with diet? Does it damage the kidneys like we've been told, or cause high blood pressure? And what about fluid intake? Because, a lot of some people comment, hey, they seem like they're more dehydrated when they're eating more protein. What's going on metabolically or physiologically in those situations?
Yeah, I think that's a really great question. I've really thought about this a lot, I think personally, because we've gone through this ourselves. And I think the answer is a little bit complicated. So we went through a period where we actually measured every single gram of salt that we used, and we ate only food that we cooked ourselves, and we made sure that the food, the meat that we got were direct from the ranchers. And so that meant they weren't being packaged, because at the grocery store, a lot of the meat that you get packaged especially chicken, is often injected or soaked in some sort of salt water that, unfortunately, the contents, they're not required to report. A lot of that actually has a lot of phosphate, but a lot of sodium as well. So, and I think after we stopped eating a lot of packaged foods and a lot of processed foods or outside of the restaurants, we found that our salt intake actually went down a whole lot. And it didn't really affect our blood pressure or thirst or whatever. And it was just more that after not eating all these processed foods, it's almost like your taste buds had changed, and that just, fresh meat cooked with like a minimal amount of seasoning. Actually, we've only used salt now. We don't even use pepper or any other seasoning, that there's just so much flavor that you don't really need any extra salt. So with regard to how much salt you actually really need, I think that's a really hard question. And that's one thing that I think if you were able to reset your body to eating natural foods, your body will tell you how much you need by way of, kind of salt, either thirst or for water, and kind of your salt appetite. But that's one thing. Another thing that I would say is, for people who are coming into this diet who have been for years metabolically ill, especially if it's metabolic syndrome, type 2 diabetes, obesity, and you've been in a hyperinsulinemic state, and you abruptly change into a low carb or a carnivore diet, you will sustain a period, which I think is variable amongst different people, of an acute diuresis, right? So you take away that hyperinsulinemic signal for your kidney to hold on to salt, and now you're just dumping it out in your urine. And there may be a period where you will over diurese salts and other electrolytes, whereby you would have to supplement and you would have to use more than you would naturally need because of that adjustment period. And I think that is a real phenomenon and something to take into account when someone transitions from, a high carb processed food diet. And I think the period of adjustment is really going to be dependent on the person and kind of their metabolic state going into that, into the entire dietary change. And then for us, for example, like we transitioned over, I would say probably a 3 or 4 year period from kind of the standard diet to a low carb, more ketogenic to more carnivore diet. So at least for us, we didn't experience that kind of dramatic diuresis, but I definitely have heard of, and other low carb doctors have definitely reported on patients who, when they do that acute switch, they have very profound diuresis. And so for that period of time, the amount of salt that you'll need is probably going to be a lot higher than you may need at steady state. Okay. So then answering the question of, will salt injure your kidneys? And again, I think that question is so context dependent, right? So it's really going to depend on where you are in that state. So if you're in that acute diuresis phase, you're going to need probably a lot of salt, and how much, I think is really going to depend on your response to the diet and how much you're diuresing. And then once you get into steady state, I think that, my guess is that it's going to be somewhere between, 3 to 4 grams of sodium a day. But again, I don't like to put out blanket numbers. And I think that that's part of the problem with a lot of guideline-based medical practices, is because I think that there's so much more nuanced variables, and each individual person will have their own, not just metabolism, their physiology, but also their own context, right? Like some people are coming in with the obesity, metabolic syndrome, type 2 diabetes. There's another group of people who are coming into this way of eating because of autoimmune related and different inflammatory types of diseases. And so I think the context in which you first arrive and how you respond to the diet versus kind of once you're into the diet and you're starting to recover either your metabolism or your inflammatory state, how much salt you're going to need moving forward is very different. And again, if you look at, I'm not a big proponent of taking the data from epidemiologic studies, but there's some information I think to be gathered, because if you look at a lot of the results from those studies, is that really high sodium intake tends to be a problem only for people who already have established disease. And so if you're, let's say, for example, type 2 diabetic, you've already have coronary disease, you have high blood pressure, and then you don't change the way you eat and you keep eating a high carbohydrate, high processed food diet, and you're eating excessive amounts of sodium, that probably will continue to exacerbate your disease, right? So if you're really hyperinsulinemic and you keep eating tons of salt and the hyperinsulinemia is telling your kidney to hold on to salt, and that drives more high blood pressure and obviously the complications that come with uncontrolled high blood pressure, then yeah, it would be bad to eat a lot of salt. But in the context of a low carb carnivore diet where your insulin levels are really low and you're taking in salt, but your kidney, is getting the right signals and able to, control the correct amount of salt to hold onto your body and the correct amount to pee out, then you might not have any problems, right? And so I think when you're switching into this diet, possibly one thing to follow is perhaps your blood pressure. If the blood pressure is low, you're probably going to have to supplement the salt, or start taking off antihypertensive medication, for example, is typically the first thing to do. And then over time, you use the salt and kind of how you're feeling. The blood pressure is typically a good, I think, parameter to kind of follow to see if the blood pressure is too high, maybe you're still eating too much salt and it's too much sodium for your kidney to handle. And versus if you're still kind of in that diuretic phase and your blood pressure is low, then you're going to need a little bit more salt.
Let me ask you about ketones again. One of the things we hear, particularly early on when people transition to a ketogenic diet, they waste ketones. They'll have, ketones forming, ketone bodies forming in the urine. That supposedly leads to competitive a competition with uric acid, and people see uric acid rise to elevated ketone. Is that really what's going on physiologically? And what other? I know we touched on ketone metabolism. Do ketones have a net positive effect? I mean, this is not necessarily ketones produced by the kidneys, but ketones produced by the liver, perhaps. Does that have a net positive effect on kidney health, or do we know, or is ketogenesis dangerous for the kidney in any way, or what are your thoughts on that?
Okay, I'll start with the last question. So that's something I'm really interested in studying research-wise. I actually think that the ketones probably have a net positive effect on the kidney. And there have been a lot of suggestions that the ketones themselves have other roles outside of being an alternate fuel for glucose-dependent organs. And so there have been suggestions that the ketones can, act as antioxidants. It can act to change kind of gene expression in different cell types. So I think nutritional and normal physiologic ketone production is likely to have a positive effect on multiple organs, including the kidney. I think one of the issues that I think it's changing, obviously, with a lot of people studying a ketogenic diet and nutritional ketosis, is there's still kind of the stigma of diabetic ketoacidosis and other pathologic states where ketones are produced. And in those cases, at very high levels of ketones have been argued to be a problem, whether it be an acid because it can develop a metabolic acidosis. But with regard to physiologic nutritional ketosis, I do believe that there's most likely going to be a positive effect on kidney function and kidney metabolism. Addressing the first question, can you repeat that again with regard to ketones and uric acid?
Yeah, I mean, many people will see when they go on a ketogenic diet, sometimes uric acid will be elevated. And the thought behind that is that the excretion of ketones somehow interferes with the excretion of uric acid.
Okay, yeah, that's a great point. I am not as familiar with that physiology, and that's totally possible. I think some of it may interfere with different channels in the kidney in terms of kind of the overall net reabsorption or secretion into the urine. And so there could be a net reabsorption of uric acid as a result of having ketones in the urine. But I'm not as familiar with the actual physiology.
Yeah, I just, by way of just getting this information out, we see that one, uric acid is actually an antioxidant. Most people aren't aware of that, but uric acid is one of our most abundant antioxidants in our body. And we also see that people that have high uric acid levels, many of them do not develop gout at higher levels. And, usually like 6.8 is considered I can't remember the units on that, milligrams per deciliter or something, or nanograms per deciliter, whatever it is the threshold for precipitation. But we see people with 9 and 10 sitting there with no evidence of gout. And then we see people with lower uric acid with evidence of gout. So it's probably a dependent variable, would be my thought. I want to ask you about, so we know the phenomenon of, when I work out, and I exercise, my muscles get bigger. When you do cardiovascular exercise, your heart will get a little stronger. There's this thought about protein stressing the kidney out. We know that, like, for instance, pregnant women, their kidneys will enlarge. We know that people have had a nephrectomy, the remaining kidney will get bigger. We know that certain populations, I think like Eskimo, Inuit, had larger kidneys. Is protein, the theory that the stress on the kidney is a bad thing because of protein and the kidney enlarges, is that really a bad thing, or is there a problem with that? Is like having bigger muscles a problem? I know when we see people when they get older, we see significant renal atrophy. You see these people as they start to become sarcopenic and osteopenic, their kidneys shrink. So what's the thought behind protein stressing the kidney out, particularly in a maybe a normal person without established kidney disease?
Yeah, so a lot of this comes from this hypothesis, and that a large protein load or amino acid load will cause hyperfiltration in the kidney. So there's a physiologic response where the kidney will increase the GFR and to deal with that amino acid load. And so one of the consequences of hyperfiltration is there is an increase in the pressure of the filtration unit in the kidney. And the thought is that pressure over time will cause injury and damage and too much stress to that filtration unit, and that would drive kidney failure and kidney disease. But I wanted to kind of bring some historical background too to that. So Barry Brenner is the physician, the nephrologist and researcher who came up with this hypothesis. And a lot of the data that comes from it is actually from animal models where they were injured, or they took out a lot of kidney. So they either injured the kidney, so they block off the blood flow and injure the kidney that way, and then put them on a high protein diet. Or they cut out one kidney and then they actually cut out I guess the other kidney, they'll take the poles off. And so in the end, you only have like 1/6 of your kidney left, right? And then they put them on a high protein diet. And that definitely generates a lot of pressure on that remaining kidney to basically enlarge to compensate for the loss of kidney mass. And then all those remaining nephrons are going to hyperfilter, and so they'll generate a lot of pressure. And then over time, that high protein load will be a stress to the kidney and exacerbate the already underlying injury. However, that doesn't apply to people who have otherwise healthy kidneys. The other part of his research, and I think one of the reviews that he mentioned, even commented on the fact that our ancestors back in the days as hunter-gatherers, we would eat a lot of meat and a lot of protein. But the difference between the eating pattern of our ancestors and our current eating pattern is that they'll probably eat a whole lot intermittently, right? They're not eating all day long like we are in modern society. And so the hyperfiltration episodes in the kidney is intermittent, right? So it's almost like having a meal every other day or once a day, such that it sees the load, it deals with the amino acid load, it hyperfilters for a period, but then we're done. And I think one of the issues is that, again, hyperinsulinemia comes into state, and also our way of eating comes into state, where I think probably the combination of hyperinsulinemia and a heavy protein load, and people are eating all day long, that if your kidneys are hyperfiltering constantly 24/7, that could very well be a stress on the kidneys that could exacerbate or drive some sort of injury. But again, protein in and of itself, I don't think is the driving issue. And certainly if you're on this type of ketogenic or carnivore diet, you're typically not going to be grazing and snacking all day long. And so that physiology is most likely, I don't think, going to be the case where you're constantly having your kidneys hyperfilter, because you're not always having this mega load of amino acids because it's intermittent. But that's one argument. Another argument is that this could all just be physiologic. It's a normal response to a high protein load. And as you mentioned, pregnancy is a hyperfiltration state. And pregnancy is not a risk factor for end-stage kidney disease. So, and I think one other thing that I think is going to be emerging is there was a recent study that came out from, I believe it was the DCCT, so this long-term follow-up of type 1 diabetics. And they had followed patients who had GFR measurements. And it was interesting because the original hypothesis is that the patients who in early years of their diabetes, type 1 diabetes, the ones that were hyperfiltering would be the ones that end up with diabetic kidney disease. And it didn't turn out to be the case. And in fact, the ones that were hyperfiltering early on after diagnosis actually did better and had a lower incidence of diabetic kidney disease. And so, again, I think the problem is that there's been this assumption that if you have hyperfiltration, that it automatically is a pathologic state. And I think that it really is, again, there's different contexts in which it may be a bad thing. So I think if you already have pretty severe underlying kidney disease, or you have very little kidney mass left, like you've had a nephrectomy for cancer or something like that, and you have very little residual kidney tissue left, then a high protein diet and hyperfiltration in that context may be not a good thing. But otherwise, in kind of otherwise healthy kidneys, and I would say there's probably some type 2 diabetics who have some level of mild kidney dysfunction that may benefit from, the high protein, as long as it's a low carbohydrate diet, and may have some reversal of their disease, of their kidney disease. But I would say for the vast majority of people who don't have advanced kidney disease, a high protein diet, in the context of a healthy diet, so low carbohydrate, no simple sugars, and no processed foods. I think the physiologic hyperfiltration that occurs with a protein meal is not going to drive damage to the kidneys. But unfortunately, that's kind of the dogma. And so it perpetuates in the medical practice.
Yeah, perhaps that hyperperfusion or hyperfiltration rather is actually, normal physiology and everything else is relative hypoperfusion. We can make that argument, I guess, depending on where you're at. Let me ask you, because about diabetic, do we know, as you mentioned, diabetes is the number one driver for, renal failure. What about it is causing that? Is it the significant hyperglycemia, the fluctuations? Is it those high blood glucoses that seems to be doing that? Or is it somebody that's sitting there with because we see some people where they'll go on a carnivore diet and their average blood glucose will go from 85 to 92. It'll go up 7 points. Whereas we see with a diabetic, they might have fluctuations where it's frequently above 200. Again, using U.S. notes. Do we know what's causing damage, or at least do we have a reasonable estimate of what's causing it?
Yeah, I think the long-standing hypothesis has always been the glucotoxicity, so high glucose and the hyperglycemia causing kidney damage. And I actually think that hyperinsulinemia, I think, is going to be another driving aspect of kidney damage and diabetic kidney disease. And I think that, unfortunately, that's not been well addressed. And I think the reason why the SGLT2 inhibitors are doing so well is that because if you look at the data, there isn't a dramatic effect on glucose control. But my guess is that, and they're not really measuring this either in the studies, is that the overall insulin levels are lower in these patients. Because you're peeing out like 100 grams of glucose a day, right? And so it's almost like going on a lower carb diet, and the effects. I mean, there's been a lot of positive effects both on cardiovascular disease as well as kidney disease progression. So I have a very, I would love to study this if I had the manpower and time and money. But I truly believe that hyperinsulinemia is a major driver of diabetic kidney disease, and one that is unfortunately not recognized. And part of the reason why I think that is the case is for another observation of patients who have chronic kidney disease or diabetic kidney disease, and they're diabetic. So before the more recent medications that we had, once you developed chronic kidney disease, a lot of times we ended up having to put people on insulin because they wouldn't be able to tolerate any other anti-diabetic drugs like metformin. They'd be at risk for lactic acidosis, for example. And so you put them on insulin, right, to control their blood glucose. You can control their blood glucose, but then their kidney disease starts to get worse pretty rapidly. And then there's a period of time where it's kind of paradoxical, and the patients would get very frustrated because they'll say, hey, I don't understand why my kidney disease is quickly getting worse, but I don't need as much insulin. My glucose is under great control. And that period of time is where the kidney is truly failing, and it's not taking up and metabolizing insulin anymore. So one of the routes of metabolism and excretion and of insulin is the kidney. So the kidney proximal tubular cells will actually take up insulin and deactivate it essentially. And so when your kidneys are failing and not doing that function, the insulin in your body just keeps circulating for longer. So the half-life of insulin is a lot longer. And so I think that during that period, they become even more hyperinsulinemic. So there, I mean, these are all kind of observations and just a hypothesis, but I would speculate that hyperinsulinemia, just like it's kind of what's driving cardiovascular disease, and people are not paying attention to that. I think that hyperinsulinemia is also driving diabetic kidney disease, but people are a lot more interested in controlling the blood glucose than they are in normalizing insulin levels.
Yeah, interesting perspective. One last topic, if you don't mind. Renal stones, and this may fall more in the purview of urologists, I guess, because they deal with them on more an acute setting. But most, to my understanding, most kidney stones, I think, are calcium oxalate stones. But we have, different varieties where the uric acid or protein-based stones, and we know that acidification of the urine, I believe, can precipitate these, and we know a high protein diet can, through the sulfur-containing amino acid cysteine methionine, tend to drive maybe a little more acid urine, not necessarily acid blood. I mean, that's obviously tightly controlled. But how do we? Let's say you've got kidney stones, maybe uric acid or oxalate-based kidney stones. Is there any way we can fix that through diet, through lifestyle? And what's the time frame to do it? And how would you do that?
Yeah, that's a great question. And actually, as a nephrologist, we deal with the metabolic side of things. We don't do the surgical aspects of the kidney stones. And again, I also have personal experience since my husband also developed a kidney stone. So I think, again, this is, a very nuanced discussion. And I think it's going to be a lot of different contexts that matter. So if we have time, I'll go through them one by one. So calcium oxalate and uric acid stones are the most common kidney stones, calcium oxalate being the most common. They both will precipitate in acidic urine. And as you just said, and it's true, that the more protein and more especially meat, the sulfur-containing amino acids will drive a more acidic urine. But that being said, at the same time, these protein, the amino acids themselves, especially glutamine, is what drives ammoniogenesis in the kidney. And that's kind of the way of the kidney to get rid of the excess acid. It's a buffer. I'll start with calcium oxalate. So calcium oxalate, I would say, unless you have a genetic disorder whereby your intestinal oxalate secretion transporters are abnormal, or if you've had gastric bypass such that parts of your intestine you have this malabsorption and you hyperabsorb oxalate from your diet. Calcium oxalate on a well-formulated low carbohydrate carnivore diet, especially carnivore diet, you should not develop calcium oxalate stones. I say a well-formulated low carbohydrate diet because even in our own experience, a lot of people go on a ketogenic diet and then develop a kidney stone. And part of the problem is if you start eating a lot of, leafy greens like spinach, and then start making a lot of, bread or pastry alternatives using almond flour or all sorts of different nut-based flours, it's a huge content of oxalate. And so what matters is kind of what the supersaturation and the concentration of calcium and the oxalate is in the urine, in that tubule, for those crystals to form. And so if you're having a large intake, or like I said, you have some sort of intestinal problem and you're hyperabsorbing oxalate, if those two concentrations aren't that high, you shouldn't get crystals. Plus, you should be drinking enough fluid. So if you're not drinking enough fluid and your urine becomes super concentrated, then those crystals, even if you're not eating a lot of oxalate, it could precipitate. So you have to also be well hydrated. I will make a comment also, is if there have been case reports of people taking a lot of vitamin C supplements. So vitamin C is metabolized in your body into oxalate. And so that could be yet another source of oxalate that can drive the calcium oxalate precipitation. So again, I think if you look at the kind of the epidemiologic studies, I mean, animal protein intake, if you take it with a grain of salt, these food frequency questionnaire data, but that's not a very strong predictor of kidney stone formation at all, actually. But urine output, which kind of equates to how much fluid you take in, is a risk factor if you don't drink enough fluid. But interestingly, I would say sugar intake is a huge risk factor. And so fructose will be metabolized into uric acid. And so there's also been this question of, oh, if I have uric acid stones, then, stop eating meat because there's a lot of uric acid in meat. But again, I think kind of looking at the overall risk factors, it's typically more the sugar than the meat intake that's probably going to be causative. The other thing I'll mention about uric acid is that there's been a lot of research done that on uric acid stone formers, that they have some different physiology that people are trying to work out, such that they have increased endogenous acid production. So this is actually work done at UT Southwestern, where I'm currently working, is that they will take in these patients who develop uric acid stones, and they'll put them on like a standardized diet, and they compare it with healthy patients who don't get kidney stones on the same exact formulated diet. But for whatever reason, the uric acid stone formers will still make more endogenous acid, and their urine is more acidic, and kind of driving the precipitation of the uric acid stones. So if you look at that in and of itself, it's not so much the food, because they're all eating the same standardized diet, but there's something inherent about their metabolism or their physiology that they're making more endogenous acid, and they're trying to work out what that is. There's some hypotheses of maybe there's something with the microbiota that's generating inappropriate acid production. But again, I personally have this hypothesis that, again, this is going back to being hyperinsulinemic, and in an inflamed state is typically under inflammation, you have this signal to break down your muscle, right? And so if you're breaking down your muscle, that's going to be another source of kind of amino acids, right? It's an endogenous source of amino acids that could be ultimately contributing potentially to the acid load that the kidney has to deal with. So I would say that the vast majority of patients who develop kidney stones, particularly calcium oxalate and uric acid stones, again, diabetes, obesity, metabolic syndrome are big risk factors for the development of that. And I think that there are contexts within kind of your overall metabolism and your physiology could predispose you to developing a more acidic urine or developing these stone formations. But I think it, again, has to do with your dietary composition. that will drive stone formation. And so with that, I think with a pure carnivore diet, most likely I think should not be a risk factor. Again, unfortunately, when you look at the studies that people do, the participants that are in there are not your average carnivore dieter, right? And no one has done long-term studies, and I've never seen one case report of someone who went on a pure carnivore diet develop kidney stones. I have, however, with the low carb. So the low carb, if you're eating a lot of, nuts, a lot of using a lot of almond-based flours, eating a lot of leafy greens. Some people, pound the supplements, right, with vitamin C. Those are definitely, you can find them in the literature for sure. And then the last point I'd make is staying well hydrated. And that's going to be, how much to drink is going to vary on the climate that you're in, and, how much you sweat basically. But the main thing is to make sure that your urine is dilute. And so it doesn't allow these crystals to form. So as long as you keep it dilute, the crystals won't precipitate.
Yeah, I think that's pretty sound advice, and I think a lot of it's thirst drives how much water you should drink. I mean, a lot of people, it's kind of these natural feedback systems we have that if you're thirsty, drink. And I guess you can look in the. I remember when I was deployed to Afghanistan, and we had a little chart for urine because it was out and it was hot, and it was like if your urine is dark, drink more. If it's medium, drink more. Even if it's light, drink. They just kept, wanting us to drink more. It was kind of funny that they had that. There was every answer was just drink more water. But anything else that we didn't touch on that you think would be important, from the context of either type 1 diabetes or, kidney related stuff that people should know about that we didn't get to touch on?
That's a great question. I mean, I think that there are a lot of unknowns, and I think it's interesting you mentioned way in the beginning that your perspective totally changes when something happens to you or your loved one. And I think my perspective has changed dramatically in terms of how I view kind of kidney health and metabolism. And I think one of the kind of still big unknowns, and I know it's been talked a lot about in the low carb community, is the issue with the seed oils, and how that may affect kidney health. I think is unknown, and I wish there was more information about that. And I think that is a variable that's not accounted for in any of the studies. And that has brought home, I think, a lot in terms of making it really hard to make blanket statements about things. And I think that's been one of the biggest tragedies of how healthcare has evolved over time, because we're so dependent on guideline-based practicing that we've kind of forgotten to consider all variables, which I think we should as good scientists and good physicians, right? Because everything that we eat, I don't think can be just broken down to just carbs, proteins, and fats. And in fact, probably the type of protein might even matter. So I'll end with this. So even being on a carnivore diet, I would say there can be an issue with the type of meat that you eat. So for example, I would say chicken, when you purchase it at the store, they will soak it or inject it with a lot of this salt solution, which apparently the food industry is not required to report because the salt solution is thought to otherwise be safe. But the salt solution tends to be very high in phosphate, partly because the phosphate also functions as a preservative, so it increases the shelf life. So I'm not even talking about processed meat or packaged meat. I'm talking about, a fresh piece of chicken breast or whatever that's just packaged at the grocery store. And if you look at the label, it will say that it's been soaked in some sort of salt solution, or they call it broth, right? And it increases the weight, and so you're getting less for your money, actually. But there are suggestions that high levels of inorganic phosphate can be damaging to your kidneys over time. And inorganic phosphate is something that's added to a lot of our foods, as a preservative in packaged foods, a lot of soda. So, all your colas are going to have phosphoric acid. And there is, growing evidence that inorganic phosphate intake can drive kidney damage. But these are all hidden variables that are not ever accounted for in any of the studies that we do, because it's, for one, it's not even on the label, it's not reported, and people are not going to tell you that, right? And even for all the studies that do protein intake, yes, sometimes they do divide it into red meat or processed meat or whatever, but vast majority of the time, protein is protein, right? If it's coming from an animal, it doesn't matter, how they ate it. It's just in one generic category. So, and I think that that's one of the biggest unfortunate parts is that we take a lot of the data that we see published and not consider all the hidden confounding variables that may be affecting the conclusions or the results. And there's way more, the kidney being especially quite complex, it's very difficult to take all of these generalized conclusions from these studies and make blanket statements about whether or not something is harmful to the kidney. It may not be the protein in and of itself, but it's how you ate it and where it came from that could possibly be the problem.
Yeah, excellent point. We've got actually, I see the same things occurring with seafood. We've got actually, we're going to have a guest coming on that has a wild, sustainable seafood company. And I talked to them previously before we're going to do the podcast with them. And they say things like shrimp, for instance, a lot of times you cook shrimp and it shrinks just tremendously. It's because they've so incredibly, saturated it with these, solutions to bulk up the thing. And so when you get truly wild caught stuff that hasn't been adulterated, you don't have that shrinkage. So when you sit there and you cook up some shrimp and when you're done cooking, it's a third of the size. It's because it's all that probably phosphoric acid or phosphate containing solutions and salt solutions. So interesting stuff. Well, this has been so fascinating. Thank you so much for doing this. And good luck with your continued success with your research. And hopefully we can start to change, or at least people open their mind up a little bit to look at some of this stuff and get out of that entrenched Brenner hypothesis dogma from the 1980s, or all that stuff that I think it's not helping us. Where can people go to find out more about anything you're talking about, maybe support your research or learn more about your research? Where would they find you?
Sure. I have to say I'm not really active on social media. I do have a Twitter account, and it's under Dr. Sarah Huen. So you should be able to find me there. I will say though that I'm not super active. I've been pretty busy with trying to get my lab going. So, but I do check up on my Twitter account on occasion. So.
And I can't tell you that social media is necessarily a good or bad thing for many people. It's more hassle than it's worth, but thank you again for so much. Thanks for being part of the community, and hopefully maybe you can update us down the road a little bit if some more information comes out. Would you be willing to do that?
Yeah, sure. Absolutely.
Thank you. And good luck with your husband, by the way. Hopefully, we've seen so many people with resolution or significant improvement of autoimmune diseases within this community. I think there's something there for sure, whether it's PKD or some other version of carnivore low carb. I think that fact alone, irrespective of weight loss and all the other stuff that people argue about, I think those things, it's very fascinating to me. And I think it's something that deserves more interest. And I know there's many, whether it's lupus or other autoimmune disorders that affect the kidney, there may be something big here. And it'd be interesting to get someone that would be willing to, not only willing to, but have the resources to look into that. And hopefully maybe that'll be part of your deal.
Absolutely. Well, thank you. It's been a pleasure I feel kind of privileged to be invited into the community and to be able to share some of my thoughts.
Well, I mean, we certainly benefited from your expertise, and thanks so much. And have a great rest of your Sunday. And thanks for taking the time. And hopefully, enjoy your time in Texas.
All
Okay,
right,
guys.
yeah.
All right, we'll see
Thanks.
you guys back tomorrow. Take care, everybody. Bye bye now.